In some cases, we do know the cause. For instance, toxic exposures can cause fibrosis. So that fibrosis is kind of the end stage, the end result of a lot of different insults, okay? And some of those insults we can point to and identify and say, yep, that causes fibrosis and scarring. But there certainly are a lot where we've not yet figured out all the steps, all the mechanisms by which fibrosis occurs, and why Ira gets it, Lynn does.
Okay, so many years ago, you diagnosed me with COPD, and emphysema went right along with it. Now, I'm starting into asthma. Does that usually follow along with it?
Well, you know, some of this may be how people choose to use these words, okay? And different people will use different words to mean use the same word to mean different things. To me, asthma means that you have a lot of fluctuation in your lung function. Perhaps that's what you're experiencing now. Whether you want to be a purist and say, well, no, that's not really asthma, that's COPD with an asthmatic component. It's a lot of, you know, how you want to use those words and what you mean by it. You know, we treat both asthma and COPD with similar medications. There are some medicines that clearly work in asthma and don't have any effect with COPD. But there's a large group of medicines that really overlap and are useful for both. So that distinction becomes a little bit arbitrary. Did I answer your question?
Yeah.
Am I talking around everyone's question?
After 45 years of smoking,
Yeah.
and it's been 25 years since I quit, will my lungs ever regenerate and go back to the way that they were?
No.
No.
No. Yeah, but, you know, that doesn't mean you just say, oh, well, I'm throwing in the towel. But, you know, what you want to avoid is further worsening. You know, it would be nice to say, I'm going to stop smoking, and all of a sudden I'll just get better and better every single day. Well, life's not that way. But if you, instead of getting bad at that rate, you kind of level it off, to me that seems like a big advantage.
Well, I know how much good that the respiratory therapy upstairs has done for me.
Pulmonary rehab.
Yeah. And I guess I'm just hoping that they'll get busy and go back.
Yeah. Well, you know, when people ask me about that, the pulmonary rehab doesn't make your lungs regrow, but it makes everything around your lungs better. And again, an analogy that I've used for some patients, and apologize if you've heard me say it before, is if you imagine a car that's out of tune and the tires aren't inflated properly. Well, getting the tires inflated properly, the car is going to run better, even if it's out of tune. So the end result, performance of the car, is better, even though you haven't fixed one component of what's wrong.
Okay, thank you.
Yeah.
You're talking about smoking while in your lungs. How does chewing affect your lungs if you have acid reflux?
Well, chewing tobacco will increase your risk of cancer in the mouth. It will affect your heart because you're absorbing some of the nicotine. It's probably not going to lead to emphysema, but it will cause other bad things. So, if you ask me, would it be better to chew tobacco than to smoke? Well, I guess, but
Yeah.
but we don't think of chewing tobacco as leading to emphysema and COPD.
Well, not necessarily leading to it, but does it make it worse?
Not to my knowledge. Okay. So I guess if you aspirate it, whether it's chewing tobacco or anything else, and it gets in your lungs, that's going to affect your lungs. But that's perhaps a little different question. Yeah.
Is there any local research going on now as far as improvement with them and improvement? Anything, or
some of the current research, you know, a lot of the medicines we've looked at in the past have been medicines that are bronchodilators, that open up the airways, and we've kind of gotten better and better with those. More current research is focused on use of medicines that reduce inflammation and help prevent inflammation. Some of the same types of drugs that you might use for arthritis, for instance, to reduce inflammation there. We think that reducing inflammation in the lungs may help. That's a little different approach. Whether that actually leads to an increase or just a prevention of worsening is another story. My own personal view is we're likely to see a prevention of worsening, not we're going to give you this medicine and you're going to regrow new lungs. It would be nice, but I don't know if that's going to happen.
I just have one more question.
Yeah.
When you do pulmonary rehab, is there, when I worked out in pulmonary rehab, I use oxygen. So I can go a certain speed and a certain incline on the treadmill. Is it better or more effective to work out without oxygen and go slower and a more level speed? Or is it better to push yourself with the oxygen, do a higher elevation and faster speed?
Use the oxygen and exercise longer and harder. You know, if you think about it, if by using oxygen you can exercise longer, you will get more exercise. I mean, it's just only common sense would tell you.
It's not going to build up anything more. It's not going to affect it.
Well, think of it this way. If I can exercise for 10 minutes without oxygen, I can exercise 20 minutes with oxygen. If I use oxygen, I'm going to get twice as much exercise. And to the degree exercise will improve your muscles, not make you regrow new lungs, but improve your muscles that are also important in your sensation of shortness of breath and in your performance, then yes, that's useful.
Just as important as endurance is an upper body strength enhancement. One of the keys to, I know that endurance is a factor that everyone wants to strive for, but upper body strength as well.
Right.
I think that would goes to that as well.
Yeah, so for instance, patients that say, I get short of breath carrying the groceries. I mean, that's a very, right? My head's going up and down. So increasing that upper body strength will help with that sensation. It's a good point, thank you. Yeah,
What about the new medicine that's out, Delorest?
Dallas.
What's your opinion on that?
Well, you know, it's different than the medicines that most of y'all are familiar with, bronchodilators and steroids. It seems to decrease the frequency that people have exacerbations. And which are these episodes where you go from one level to all of a sudden you're a lot sicker, coughing, bringing up a lot of mucus. And one thing we've learned is that when you get worse, when you drop a foot from that, you usually come back only 11 inches. So that these recurrent episodes are one thing that carries you down over time. And we think that by preventing exacerbations, you'll have less of that downward trend over the years. Now, Dalorest has been shown to decrease the frequency of exacerbations. But it's not going to be a pill where you take it and the next morning you say, well, I feel better. But it might result in you feeling better a year from now than you would had you not been on it. That's a harder thing in a given individual to sort out. And it really relies studying large groups of patients to say, yep, folks that were on it did better than folks that weren't. So who would I use that drug on? I'd use it in someone who's had frequent episodes of exacerbations and maybe not so frequent, like 1 or 2 a year. Or someone who I have on chronic steroids. Maybe we can use this to help either prevent going on chronic steroids or get them off of chronic steroids. That's how I would approach it.
Okay, that's what Dr. Hay did with me
little high dosage of the Advair, modified the dosage of the Advair and put me on the Daliresp. And I can say, knock on wood, that it's been a year since I had any serious
episodes, any
Yes,
exacerbation.
exactly.
And that's kind of, but you probably didn't take it on a Tuesday and feel better on Wednesday.
No, no. But over the long haul, and it seems like if I've gotten like a little sinus infection that used to go right immediately into the lungs, now I can cure the sinus infection and it not go there. So
You don't have as much of an inflammatory response that causes a lot of the problems.
that's exactly correct.
A real quick question, because I was writing things down and then I thought, oh, if I go tell my father-in-law this, I know what he's gonna do. You said maybe if we can take them off chronic steroids and replace with Daliresp. You're not talking about like a 5 milligrams maintenance drug per day. You're talking about more of like taper down, frequent taper.
No, I would consider it a patient who's on 5 milligrams a day. If I'm using the 5 milligrams because they keep having these episodes and I'm using it to blunt the intensity of those exacerbations. As opposed to someone, kind of like a father-in-law,
That's what I'm getting at. I don't want to give them
who,
a wrong
every
answer.
time we go from 5 to 2.5, I'm having trouble. Daliresp probably not going to help.
Okay, thank you. Thank you for clearing that up.
Yeah, sure. Yeah.
Like the lady over here, I went from Advair 550 to Logan. But from what I recall, it was because of like some chest pains or palpitations. I can't hear you.
Yeah, so you went from Advair to Flovent. And
Yes.
right.
Yes.
Advair has 2 ingredients. One is Flovent,
Right, and then silent mineral.
and the other is a long-acting beta agonist, sort of like a long-acting version of albuterol, which a lot of people probably own. And one side effect of beta agonists is increasing your heart rate. Sometimes people could have chest pain. Those aren't real common sorts of symptoms or limiting symptoms, but they can be in some patients. So they got, instead of having Advair with 2 ingredients, they just kept the inhaled steroids, which is probably the more important of the 2 for asthma, because you've had less of the side effects from the heart. Mm-hmm. Yes, sir.
Getting back to the relationship between oxygen and some of these attacks, will oxygen help